I've been feeling so tired lately, and sometimes I get dizzy when I stand up. Could I be an anemic? I take some iron supplements. These questions echo across doctors' offices worldwide, reflecting a common yet often misunderstood health concern. I'm Dr. Amelia Chen, hematologist and medical educator, and today we'll explore anemia, a condition affecting millions globally yet frequently overlooked or self-diagnosed incorrectly. Anemia isn't simply being tired or having low energy. It represents a complex physiological state where your body lacks sufficient healthy red blood cells to adequately carry oxygen to your tissues. This oxygen deficit creates a cascade of compensatory responses throughout your body systems, manifesting as diverse symptoms that can range from barely noticeable to severely debilitating. What makes anemia particularly challenging is its nature as both a condition itself and a symptom of numerous underlying health issues. From nutritional deficiencies to chronic diseases, hereditary disorders to acute blood loss, anemia serves as a warning signal that something requires attention. Understanding this condition empowers you to recognize important symptoms, seek appropriate evaluation, and avoid the pitfalls of misguided self-treatment. Let's begin by understanding the fundamental components of blood and how they contribute to your overall health and vitality. The Three Musketeers. Understanding blood cell types. Your blood contains three primary cellular components, each serving distinct yet interconnected functions. Think of them as specialized teams working in harmony to maintain your health. Red blood cells, erythrocytes, serve as the oxygen transport system. These remarkable cells, shaped like biconcave discs to maximize surface area, contain hemoglobin, the iron-rich protein that binds oxygen and gives blood its characteristic red color. Approximately 25 trillion red cells circulate through your body, each living about 120 days before being recycled by your spleen. Every second, your bone marrow produces about 2 million new red cells to replace those completing their life cycle. White blood cells, leukocytes, function as your body's defense force. Unlike the uniform red cells, white cells come in several specialized varieties, each targeting specific threats. Neutrophils combat bacterial infections, lymphocytes address viral challenges, eosinophils target parasites and allergic responses, and macrophages clean up cellular debris and foreign material. When you develop an infection, your white cell production increases dramatically. This explains why infection often raises your white blood count on blood tests. Platelets, thrombocytes, form your emergency response team for bleeding. These tiny cell fragments patrol your bloodstream, instantly responding to vessel damage. When you experience even minor trauma like bumping your arm against a table, platelets immediately gather at damaged sites, aggregating to form plugs that prevent bleeding. This happens constantly throughout your body, often addressing microscopic vessel injuries you never notice. The silent champions, red blood cells, and oxygen transport. While all blood components play crucial roles, red blood cells deserve special attention when discussing anemia. These specialized cells represent the culmination of a complex maturation process that begins with stem cells in your bone marrow. Every red blood cell contains approximately 270 million hemoglobin molecules, each capable of carrying 4 oxygen molecules. This remarkable efficiency explains how your relatively small blood volume can deliver sufficient oxygen to sustain life. When you breathe, oxygen diffuses from your lungs into red cells passing through pulmonary capillaries. These oxygenic cells then travel through your circulatory system, releasing oxygen to tissues based on their metabolic demands. What makes this process particularly fascinating is its dynamic nature. Hemoglobin's affinity for oxygen changes based on local tissue conditions. In areas with high carbon dioxide levels, indicating active metabolism, hemoglobin releases oxygen more readily, a phenomenon called the Bohr effect. This ensures tissues working hardest receive proportionally more oxygen, optimizing resource distribution throughout your body. The red cell's unique structure facilitates this vital function. Its flexible membrane allows it to squeeze through capillaries narrower than its diameter, while its biconcave shape creates optimal surface area for gas exchange. A healthy red cell can change shape repeatedly without rupturing, navigating the circulatory labyrinth thousands of times during its lifespan. Defining anemia. When oxygen delivery falls short, anemia develops when something disrupts your body's oxygen transport capacity. This disruption can stem from insufficient red blood cells, inadequate hemoglobin within those cells, or abnormal red cell structure that impairs function. Regardless of cause, the end result remains similar: tissues receive inadequate oxygen for optimal function. Clinically, anemia is defined through specific laboratory parameters. For hemoglobin below 13.5 GDL indicates anemia, while women's threshold sits slightly lower at 12.5 GDL. This gender difference acknowledges women's regular blood loss through menstruation. Elderly individuals may have slightly adjusted thresholds as well, reflecting age-related changes in bone marrow function. Beyond hemoglobin, complete blood count (CBC) reveals other important parameters. Red cell count quantifies actual cell numbers, while hematocrit measures the percentage of blood volume occupied by red cells. Mean corpuscular volume (MCV) indicates average red cell size, a crucial diagnostic clue that helps categorize anemia types. Red cell distribution with RDW measures size variation among your red cells, with increased variation often signaling ongoing abnormal production. Together, these values create a comprehensive picture of your red cell status. While hemoglobin remains the primary diagnostic criterion, these additional parameters help identify underlying causes and guide appropriate treatment approaches. The many faces of anemia, understanding common causes. Anemia develops through three primary mechanisms: decreased production, increased destruction, or blood loss. Within these categories lie numerous specific causes, each with unique characteristics and treatment approaches. Iron deficiency represents the most common nutritional cause worldwide, since each hemoglobin molecule contains 4 iron atoms. Inadequate iron intake or absorption directly impairs hemoglobin synthesis. This typically develops gradually as iron stores deplete, often due to dietary insufficiency, malabsorption, or chronic blood loss, commonly from menstrual bleeding or gastrointestinal sources. Classical signs include small, pale red cells, microcytic, hypochromic anemia. On bloods, vitamin deficiencies, particularly B12 and folate, disrupt red cell maturation, causing large immature cells, macrocytic anemia. These nutrients serve as essential cofactors for DNA synthesis during cell division. Without them, developing red cells cannot divide properly but continue growing, creating abnormally large cells with compromised function. B12 deficiency additionally causes neurological symptoms due to its role in nerve health. Chronic diseases frequently cause anemia through multiple mechanisms. Inflammation disrupts iron utilization, kidney disease reduces erythropoietin, the hormone stimulating red cell production, and bone marrow disorders directly impair the production site. Genetic conditions like sickle cell disease and thalassemia cause structural hemoglobin abnormalities, while autoimmune conditions may trigger premature red cell destruction. Recognizing the warning signs. Symptoms of oxygen deficit. Anemia symptoms directly reflect tissue's responses to oxygen shortage, with severity proportional to both the degree of anemia and its development speed. Your body's remarkable adaptability means gradually developing anemia often causes milder symptoms than rapid onset, even at identical hemoglobin levels. Fatigue represents the universal symptom, the quintessential manifestation of inadequate oxygen delivery to muscles. This differs from ordinary tiredness. Anemic fatigue typically persists despite rest and worsens disproportionately with physical activity. Many patients describe needing to rest after climbing a single flight of stairs or finding household chores suddenly overwhelming. Cardiovascular symptoms develop as your body compensates for reduced oxygen carrying capacity. Your heart pumps faster and harder, creating palpitations, rapid heartbeats, tachycardia, and occasionally chest pain during exertion. These compensatory mechanisms maintain oxygen delivery in the short term but stress your cardiovascular system over time. Neurological symptoms reflect your brain's sensitivity to oxygen levels. Dizziness, headaches, and concentration difficulties frequently occur. Some patients describe a peculiar brain fog, difficulty focusing or processing information that frustratingly interferes with everyday tasks. More severe anemia can cause vertigo, particularly when changing positions, orthostatic dizziness. Visible changes often appear as anemia progresses. Pallor develops most noticeably in mucous membranes, inside lips, gums, and lower eyelids, and nail beds. In darker-skinned individuals, examining the palms or tongue often provides better assessment than facial skin. Brittle nails, hair loss, and angular cheilitis, cracks at mouth corners may develop, particularly with iron deficiency. Beyond laboratory values, the clinical manifestations. While laboratory tests definitively diagnose anemia, understanding its clinical manifestations helps recognize when testing becomes appropriate. The body's response to anemia creates a constellation of signs that astute observers, including patients themselves, can identify. Respiratory adaptations often develop, with breathlessness during activities previously handled easily. This dyspnea occurs because your lungs attempt to compensate for reduced oxygen capacity by increasing respiratory rate and depth. Some patients describe needing to catch their breath after speaking full sentences, a subtle but telling sign. Temperature sensitivity frequently increases, with many anemic individuals feeling perpetually cold, especially in extremities. This occurs as your body prioritizes core temperature regulation, reducing circulation to peripheral areas. Cold hands and feet that seem disproportionate to environmental temperature often signal this compensatory response. Unusual cravings sometimes emerge, particularly with iron deficiency. The condition called pica involves craving and consuming non-nutritive substances like ice, clay, paper, or dirt. While its exact mechanism remains unclear, pica often resolves with appropriate iron therapy, suggesting a connection to metabolic changes in deficiency states. Immune function may diminish in certain anemia types, leading to increased infection susceptibility. This proves particularly common with vitamin deficiencies that affect white cell production alongside red cell development. When anemia and frequent infections coincide, comprehensive blood count evaluation becomes especially important. Diagnostic approaches beyond hemoglobin levels. While identifying anemia begins with hemoglobin measurement, proper diagnosis requires a systematic approach to identify underlying causes. This process combines laboratory testing with careful clinical evaluation. Complete blood count (CBC) provides the cornerstone of anemia assessment. Beyond confirming low hemoglobin, this comprehensive panel reveals critical information about red cell characteristics. 1105th Samine corpuscular volume classifies anemia by cell size. Microcytic small cells suggests iron deficiency or thalassemia. Macrocytic large cells points toward vitamin deficiencies or certain medications, and normocytic normal-sized cells may indicate chronic disease or blood loss. Red cell morphology assessment involves microscopic examination of blood smears. This reveals structural abnormalities like hypochromia, paleness indicating reduced hemoglobin. Poikilocytosis, irregularly shaped cells, or target cells as cells resembling shooting targets. These distinctive patterns provide valuable diagnostic clues that narrow potential causes. Iron studies measure serum iron, ferritin's iron storage protein, transferrin iron transport protein, and total iron binding capacity. These values collectively reveal not just current iron levels, but your body's iron storage status, crucial for distinguishing between true iron deficiency and other conditions with similar presentations. Additional tests target specific suspected causes. Vitamin B12 and folate levels. Hemoglobin electrophoresis identifying abnormal hemoglobin types. Reticulocyte count measuring new red cell production. And occasionally bone marrow examination when production disorders are suspected. Special considerations: anemia in women. Women face unique anemia challenges due to reproductive physiology. Monthly menstrual blood loss creates ongoing iron demands that dietary intake may struggle to meet. A typical menstrual period loses 34 ml of blood, containing approximately 15-20 of iron, a substantial portion of the recommended daily intake. Pregnancy dramatically increases iron requirements, as maternal blood volume expands by nearly 50% while simultaneously supplying iron for fetal development and placental growth. During pregnancy, iron needs increase from 18 mg to 27 mg daily, an amount challenging to obtain through diet alone. This explains why prenatal vitamins contain substantial iron supplementation. Postpartum blood loss further challenges iron stores, particularly following complicated deliveries or cesarean sections. Without adequate replenishment, this can lead to persistent fatigue, often mistakenly attributed solely to new parenthood demands, rather than underlying anemia. Gynecological conditions affecting menstrual flow like fibroids, endometriosis, or adenomyosis can substantially increase monthly blood loss, sometimes causing iron deficiency anemia resistant to oral supplementation. When heavy periods consistently soak through tampons or pads hourly, or require double protection, quantifying blood loss and evaluating for anemia becomes essential. For these reasons, women generally benefit from routine hemoglobin screening, particularly before pregnancy, during prenatal care, and when experiencing heavy menstrual bleeding or unexplained fatigue. Proactive identification allows timely intervention before significant symptoms develop. While recognizing anemia represents an important first step, appropriate treatment requires addressing both the anemia itself and its underlying cause. Treatment approaches vary widely based on anemia type, severity, and individual factors. Nutritional anemias respond to targeted supplementation. Iron deficiency requires iron replacement, typically through oral supplements containing ferrous sulfate, ferrous gluconate, or ferrous fumarate. These supplements work best when taken with vitamin 100th to enhance absorption, and between meals to avoid binding with foods that reduce availability. Liquid or chewable formulations often cause less gastrointestinal distress than pills. Vitamin B12 deficiency treatment depends on its cause. Dietary deficiency responds to oral supplements, while absorption problems are common in older adults or after certain gastrointestinal surgeries, require monthly B12 injections that bypass the digestive system. Folate deficiency typically resolves with oral supplementation, with higher doses recommended during pregnancy to prevent neural tube defects. Blood transfusions become necessary for severe anemia causing significant symptoms or hemodynamic changes. While not addressing underlying causes, transfusions rapidly restore oxygen-carrying capacity when immediate intervention becomes necessary. Each unit of packed red blood cells typically raises hemoglobin by approximately GDL in average-sized adults. Medications stimulating red cell production, primarily erythropoiesis-stimulating agents ESAs, benefit certain chronic conditions, particularly kidney-related anemia. These injectable medications mimic natural erythropoietin, signaling your bone marrow to increase production. They require careful monitoring due to potential cardiovascular complications when used inappropriately. Prevention strategies maintaining healthy red cell production. While some anemia causes remain unavoidable, nutritional strategies can prevent many common forms and support overall red cell health. Iron-rich foods form the foundation of prevention. Animal sources heme iron offer superior bioavailability, with beef liver, oysters, sardines, and lean red meat containing the highest concentrations. Plant sources non-heme iron include legumes, spinach, tofu, and fortified cereals. Combining these foods with vitamin 100 sources enhances absorption, for example, adding orange segments to spinach salad or tomatoes to lentil soup. Strategic meal planning helps maximize nutrient absorption. Calcium significantly inhibits iron uptake, making it advisable to separate calcium-rich foods or supplements from iron-rich meals by at least 2 hours. Similarly, tannins in tea and coffee reduce iron absorption, suggesting these beverages are best consumed between rather than with meals. Regular screening proves particularly important for high-risk groups: menstruating women, pregnant individuals, vegetarians, vegans, endurance athletes, and those with chronic conditions affecting nutrient absorption. Periodic hemoglobin checks can identify developing deficiencies before significant symptoms emerge. Blood donation, while vitally important for healthcare systems, temporarily reduces iron stores. Regular donors benefit from iron-rich diets and occasionally iron supplementation between donations, particularly if predisposed to deficiency. Most blood centers now monitor regular donors' hemoglobin trends to prevent donation-associated deficiency. Conclusion: taking charge of your red cell health. Anemia represents much more than simply feeling tired. It signals an imbalance in your body's oxygen transport system with implications for virtually every physiological process. By understanding red blood cells' crucial role, recognizing anemia's warning signs, and appreciating the importance of proper diagnosis, you've gained valuable tools for protecting your health. Remember that while fatigue and weakness often prompt concerns about anemia, definitive diagnosis requires laboratory testing. Self-supplementation without proper evaluation may mask important underlying conditions requiring specific treatment. If you experience persistent fatigue, dizziness, unusual pallor, or other symptoms we've discussed, consultation with healthcare providers offers the safest path forward. For those diagnosed with anemia, following prescribed treatments, whether nutritional supplements, medications, or lifestyle modifications, provides the best opportunity for full recovery. Regular follow-up testing ensures treatment effectiveness and helps prevent recurrence. Thank you for joining me in exploring this common but complex condition. By recognizing anemia's many manifestations and understanding its diagnostic process, you've taken an important step toward optimizing your health and vitality. Knowledge truly empowers prevention, early detection, and effective management, the cornerstones of lasting well-being.